A small Ontario community is on the front lines of a battle against prescription opioid abuse. And joining us now to tell us why this story is indicative of the need to shift gears in the war on drugs, here's Dan Werb. He is director of the International Center for Science in Drug Policy and the author of the column Oxy Town, which is in the December issue of the Walrus Magazine. And Dan, it's good to have you here at TVO.
Thanks for having me.
Just start by telling us this International Center for Science in Drug Policy. What is that?
It's an organization we're looking at trying to produce evidence that can support evidence-based drug policies. So, we look at all kinds of research that's been done, scientific research on current drug policies, given the fact that we live in a time in which drug policies are in such fluidity. We've seen the regulation of cannabis in the United States in a bunch of different locations, and decisions like Portugal's decision to decriminalize all drugs in 2000. So we're trying to bolster the evidence in that regard and try to help policymakers when they're trying to develop better, more effective approaches to combating harms of drugs.
Fair to say that you're on that side, the side towards decriminalization, that kind of thing.
Yeah, I mean, we can get into it. Certainly, I think.
Well, we will. We will get into it. Okay, but let's talk. This story is really quite astonishing because, of course, we tend to think of some of the places where the kinds of things you're describing happening as sleepy hollows where very little goes on. Mm-hmm. You talk in this piece about a place in southwestern Ontario called Chatham-Kent. Just give us the lay of the land. What's there?
I mean, it's a beautiful place. It's a county of about 100,000 people. It's quite large, quite sparsely populated. There's a corn maze in the shape of Commander Hadfield's head, which struck me. And, it's one of these idyllic southern Ontario towns, beautiful old red brick buildings, Victorian architecture, and by all accounts, quite beautiful and quite a nice place to live.
Except for the fact that,
on the flip side, it's like a number of places in Ontario, and really, I don't want to single out Chatham-Kent, but it has been battling OxyContin addiction. So one of the best markers I have for this is, it's a town, or it's a county of 100,000 people. One of its largest towns, Thamesville, has 10,000 people in it, and Thamesville has 2 methadone clinics for 10,000 people. So that's totally disproportionate to what we would see elsewhere, even in places like Toronto.
And it has those 2 clinics because?
Because it has extremely high levels of OxyContin addiction.
How come?
Well, there's a number of different reasons. People point to the economy, the fact that it's been historically, its fortunes ebb and flow with the automotive industry and the agricultural industry, and the automotive industry has been in decline for some time there. The Chamber of Commerce for the area has said that the economy is not promising in their recent outlook. And
this is the group whose job it is to sort of promote how great things are.
Yeah.
They say it's not promising.
Exactly.
Well, they're just telling it like it is.
Yeah, they are. So, that's certainly that's part of it. But I think on a broader scale, what we've seen over the past 20 years or so across Ontario in particular is just a steady increase in the use of prescription painkillers, opioid painkillers, painkillers like OxyContin, Percocet, and more recently Oxy Neo and Fentanyl.
And just to clarify, it's not because people are getting hurt and therefore need this to deal with their pain. This is strictly drug abuse in your view, is that right?
No, I think initially there's a number of reasons why people would be prescribed these drugs. And particularly, a lot of blue-collar jobs, there's higher potential for accidents on the job. So people require painkillers because, they might need surgery or they might be in chronic pain. So there are very legitimate reasons why people are prescribed opioid painkillers, and I fully support that, and there's absolutely no problem with that.
Except I think I read somewhere in here, you got, in 2007, almost 30% of high school students in Erie St. Clair Local Health Integration Network, an area that includes Chatham-Kent, admitted to having used prescription opioids for non-medical purposes at least once in the previous year. I mean, that sounds high.
Yeah, it is high. It is high. And the issue there is not the fact that people are being prescribed these drugs, but that they're being overprescribed these drugs. So say you go in for a routine surgery, instead of being provided with maybe 14 pills of OxyContin that you can use to numb the pain in the few weeks after your surgery, people have been provided or prescribed, 100 pills, 200 pills, 300 pills.
That suggests that the medical clinicians or the pharmacists or whoever are not doing something kosher here. Is that what you mean to say?
Yeah, certainly. I mean, I don't know whether people, I assume that people, the prescribers of these drugs are not doing it to promote drug addiction, certainly, but there hasn't been proper management or education, I think, of the medical profession in terms of their responsibilities to limit addiction. And I think part of that is certainly education within the medical system.
I don't know this, but on the other hand, you can imagine a scenario where a patient comes to the doctor and says, my pain is off the charts, you didn't give me enough last time, you got to double the dosage, you got to double the potency, et cetera, come on, doc, you got to help me. And you'd be a pretty heartless doctor not to indulge in that, right?
Absolutely.
So that's part of what's going on here.
Certainly, and the stories that I was told by people in Chatham-Kent was that kind of thing was happening, and people were simply taking these drugs and diverting them to the street and reselling them, using maybe some of them because they were drug dependent themselves, but then selling the rest to make money.
And how much can you make doing this?
Well, one patch of fentanyl, which is an incredibly potent opioid, 50 to 100 times more powerful than morphine, is worth $400 on the street. And that's one patch. That's one patch.
And if somebody has a good week, they can sell how many patches?
Well, it depends on how many they're prescribed. But one of the other issues with fentanyl is that you can cut up these patches and then divert them in a million different ways.
You started by saying you don't want to pick on Chatham-Kent, but because the fact of the matter is this is not obviously a problem that's limited to a small southwest Ontario community. Is this across the province?
Absolutely it is. Absolutely. In 2013, there were 621 overdose deaths related to opioids in the province. And that's more than half of all the opioid-related overdose deaths in Canada. So Ontario has the lion's share of problems in this regard. Particularly in the north, there are really high levels of addiction. Some northern Aboriginal communities have reported addiction levels to opioids of 70% of their communities, if you can imagine. But Chatham-Kent, I think, is really interesting because it's also a very rural area. So, we associate drug addiction with big cities, with metropolitan areas, but clearly this is a problem that's kind of crossed the cultural divide, if you will.
Remind me when this happened, but it was 2 or 3 years ago, I think, that the Ontario government stepped in and said, we understand this is a problem, we are outlawing OxyContin, and we're going to replace it with something else, thinking that that was going to end this problem. Didn't work, I guess, eh?
Well, it's not exactly what happened. They did put some restrictions on a new form of OxyContin called Oxy Neo, which was claimed to be tamper-resistant, but Purdue Pharma actually stopped production or distribution of OxyContin in the first place. People say that they were motivated, they claim to be motivated by trying to reduce the tamper possibility of their drug. Some point to the fact that the patent on OxyContin was about to end, so they wanted to introduce a new drug to the market. In any case, they replaced OxyContin with Oxy Neo. Oxy Neo is in fact much more tamper-resistant in principle. It's a slower-acting drug. You can't crush it up and inject it because it's too difficult to crush up. And the provincial government did put restrictions on Oxy Neo.
Has that changed anything?
Well, it has changed things. Certainly, the levels of Oxy Neo dispensation are about 60% of what we saw for OxyContin. Now, unfortunately, what we've seen is an increase in deaths related to fentanyl, this drug that we were talking about before, that is 50 to 100 times more powerful than morphine. So, where people who are drug dependent were previously relying on OxyContin to feed their drug addictions, it seems that people have now started to use fentanyl. which is obviously problematic.
Tell me this, I mean, if you want to get high, why are the people who are involved in this whole thing, not just smoking grass or doing coke or what so many other people do? Why are they going for this?
Because I think there's a number of reasons. One, it's incredibly available. I think also the fact that it's in pill form, it's processed, it's very easy to know what the dose is that you're using. For that reason, it's much more attractive than a street drug. And frankly, it's an incredibly refined product. I mean, there are multi-billion-dollar companies that are putting incredible amounts of R&D into producing these highly effective drugs, these highly effective products.
And if you're part of the, I think, 85 to 90% of Ontarians who are on a drug plan, somebody's actually going to pay for this for you.
Mm-hmm. And that's actually one issue, is the fact that, because opioids interact with the human body in such an incredibly efficient way, opioid-related drugs, or drugs that contain opioids, are more effective in a lot of ways. So they're more likely to be covered by our drug plans.
But let's just, think about the absurdity of that for a second. We have a drug abuse problem here, which the province of Ontario is helping to subsidize, and which employers are helping to subsidize because they will pay for you to use these drugs.
Mm-hmm.
That's crazy.
It is crazy. On the other hand, these drugs are incredibly useful. There's a reason that morphine, for example, is on the World Health Organization's list of essential medicines, because it is fundamental to our health
Great pain
system.
Management drug.
Exactly.
Huh. Okay, let's just go through the sort of list of, I hate this word, but for lack of a better word, the stakeholders who are a part of the prescription painkiller problem. You've got, as we've mentioned, the government of Ontario. You've got pharmaceutical companies who make the stuff. You've got doctors who prescribe the stuff. You've got pharmacists who dispense the stuff. You've got local law enforcement who obviously understand that this is a problem that they've got to get involved in as well. Is there any attempt by anybody to get all of these different groups together on the same page so that you can make some progress on this?
Mm-hmm. And there have been efforts, certainly. The federal government, and through the Canadian Centre for Substance Abuse, has released a report called First Do No Harm in last year, that they were laid out a number of recommendations for better integration of all these different stakeholders, as you mentioned. The Ontario College of Surgeons and Physicians has also unilaterally, well, not entirely unilaterally, but working with the Ontario government, has sought to restrict prescriptions on the medical side and educate their, the doctors in the province on the dangers of this drug, or this class of drugs. I would suggest that, and I think we have seen some differences. Like I said, Oxy Neo prescription is at about 60% of what OxyContin was. So and that's good news. Yeah, that is progress.
All right, but having said that, there's still a problem. So does your institute purport to have a solution as to what to do here?
Well, I would point out that, there's this thing called the balloon effect, which I mentioned in the magazine article. And that's this effect that we've seen all across, drug-related harms, where basically you have this balloon, it's the drug market. Say you poke one part of it, the air goes elsewhere. Sure. And this was first kind of observed in Colombia, where Plan Colombia, this multi-billion-dollar effort by the U.S. and the Colombian government to eradicate coca cultivation, to stop cocaine production in Colombia, was highly successful in reducing levels of coca cultivation in Colombia. Unfortunately, all the coca cultivation spread, or not all of it, but a large proportion of it spread to the countries around Colombia.
Balloon effect.
The balloon effect. And I think what we're seeing here in OxyContin in Chatham-Kent is a similar balloon effect, where, yes, you can restrict access to one drug, OxyContin, but what happens? We've seen increases in fentanyl use. We've seen increases in crystal meth use, so diversion back to a black market. And that is really problematic. And I think that we're going to continue seeing this cycle of shifting from one drug to another as we target particular drugs and try to restrict access to those drugs. And it's effectively unending unless we radically change our strategy.
Well, here's what you say on that, and now we're going to get into it here in our last few minutes. Instead, you write this in the piece, instead of simply improving painkiller regulation, what if we made it the responsibility of our governments to regulate the flow of equally dangerous drugs like heroin, crack, and crystal meth? I want to make sure I understand. Are you saying, let's not make this stuff illegal, let's just regulate it?
In effect, yes. I mean, we have so many different drugs that we're trying to deal with in terms of their harms. There's cannabis, there's heroin, for example. Right now, we have the same policies in place, effectively, to deal with radically different drugs. So what do we do because we don't like cannabis? We criminalize it. What do we do because we don't like heroin? We criminalize it. Now, these are drugs that have an entirely different effect on individuals and society. And there are a number of different policies in place that can be refined to the issues related to every single drug uniquely that we could put in place. So, for example, there's a model of regulation called heroin prescription or heroin-assisted therapy. So people who are addicted to opioids, heroin, if they failed conventional therapy like methadone, in some countries, they're given access to something called heroin prescription, and that is they're able to ingest heroin under the medical supervision of a medical professional, and they're provided it for free to effectively end their reliance on a black market, to stabilize their lives. And what they've seen is an incredible increase in health-related outcomes, positive health-related outcomes.
Who does this right now?
Well, one of the pioneering trials was in Vancouver, in fact, the Naomi trial. Right now, heroin prescription is not available in Canada. It is available in a number of Western European countries, including the UK. And
you think the outcomes are better than the status quo?
Well, yes, certainly. If people don't have other effective treatment options, then yes, heroin prescribed under medical supervision, consumed under medical supervision, has been shown in the scientific literature to be an effective way of reducing harms.
You see any appetite among any of the political leaders in this country to go in that direction?
I think it's too controversial at this point, but I would point out that, this is this isn't regulation as people consider it. It's not like you walk into a corner store and you can buy a pack of heroin like you could buy a pack of cigarettes. This is an entirely different system.
You shouldn't do that either, but that's another story.
Yeah. That is highly, highly regulated. And in fact, what we have right now when we talk about, prohibited drugs is we have massive black markets that are widely available to the majority of Canadians. So, for example, in North America, the drug that youth report having greatest access to and have for about 30 years is cannabis, number one, then tobacco and alcohol. And I don't think it's by coincidence that the drug that youth have greatest access to is the one that's illegal, whereas tobacco and alcohol are obviously regulated.
Right. Dan, we thank you for writing the piece, and we recommend it for those who want to see the December issue of the Walrus Magazine. There it is right there. Oxy Town. Dan Werb, thanks so much for being here at TVO tonight.
Thanks.
Support Ontario's public television. Donate at tvo.org.